Hi, welcome back to my next video, and today I'm going to be presenting Acanthamoeba Keratitis. Introduction. Acanthamoeba keratitis is the most common exogenous parasitic infection of the cornea with the greatest risk seen in contact lens wearers of all types. This type of keratitis has a wide spectrum of clinical presentations that often mimics herpetic keratitis and other forms of infectious and non-infectious corneal inflammation. The treatment is long and difficult, with outcomes closely associated with severity of initial corneal involvement. Prevention of this type of keratitis is improved with strict contact lens hygiene and disinfection instruction. The mainstay of medical treatment is the use of topical biguanides, but may require other antibiotic drugs as well as immunosuppression to save the eye. Biological characteristics of free-living amoeba. According to taxonomy, amoeba is a type of unicellular protozoa with a simple biological structure. There are mainly two medicine-related categories of amoebas, including parasitic amoeba and free-living amoeba. Free-living form is widely distributed in diverse natural environments as well as man-made environments. Pathogenic free-living type related with ocular infections mainly include Acanthamoeba family. Risk and predisposing factors. Contact lens wear, as I said, contaminated water or solutions, especially homemade solutions, corneal trauma, and orthokeratology. General conditions includes any age may be infected, the population of male and female patients is almost equivalent, and the majority of cases are unilateral. Pathogenesis. So amoeba can enter humans in various ways. When it enters through the eye, it can result to severe keratitis of the eye. In case of entering through the nose, it causes the infection of lower respiratory tract. But it can also enter through ulcerated or broken skin and cause granulomatous amoebic encephalitis, disseminated disease, or skin lesions in individuals with compromised immune system. Let's continue the pathogenesis of this disease in the corneal tissue. The mechanism starts with initial attachment of the amoeba, which is facilitated by its expression of a mannose binding protein, which binds to a corneal epithelial cell's mannose-ylated glycoprotein. And once bound, Acanthamoeba expresses proteases such as MIP-133, which degrade both corneal epithelium and corneal stroma, promoting invasion and ulceration. In the corneal stroma, the organism continues to proliferate and cause radial neuritis. But what we have to know about that it does not become intraocular. Clinical presentation. Manifestation of Acanthamoeba keratitis. Compared with acute suppurative bacterial keratitis, the onset of this disease is sometimes indolent and mostly chronic, which takes about 3 to 7 days after exposure to risk factors. There are all early stage, advanced stage, and late stage of this disease. At early stage, patients usually have the lesions located in the corneal epithelium and shallow corneal stroma with the following presentation: ocular ciliary congestion, roughness of corneal epithelium punctate, opacity, subepithelial infiltration, erosion. There are also rare cases of pseudodendrites or disciform-like corneal edema, as well as corneal ulcer with a diameter less than 4 millimeters, and radial keratoneuritis can be also a case in 10% of cases. What we have to also note that pseudodendrites of corneal epithelium is characterized by fine but a few branches without swelling at the end of branches, which is characteristic for herpetic keratitis. In addition, the branch edge region rarely yields dye penetration when fluorescein staining. Here we can see a few clinical samples of pseudodendrites of the corneal epithelium at early stage. At the first photo, the patient was diagnosed with Acanthamoeba Keratitis 2 weeks after the onset of symptoms. In the earliest stage, we can see here a diffuse epitheliopathy with multiple intraepithelial linear infiltrates, and these linear infiltrates onset form dendritic pattern. And on the third photo, we can see here fluorescein staining, which shows a dendritic pattern similar to herpes simplex keratitis. And in contrast to the dendrites seen in herpes simplex infection, these lesions are more irregularly shaped and do not have terminal bulbs. At this stage, the keratitis is often misdiagnosed as herpes simplex keratitis. In this slide, we can see on the first photo the radial keratoneuritis and fluorescein staining along the radial nerves. And here we can see a corneal subepithelial infiltration, and on the third photo is a female patient, 20 years old, with a corneal epithelial swelling and some infiltration of a shallow stroma. Here we can see a disciform-like corneal edema, a female patient 13 years old with a history of contact lens wear with disciform-like corneal edema. And on the second photo, it's a patient 32 years old with disciform-like corneal edema, also with a history of contact lens wearing. Then superficial stromal ulcer is also a typical sign of early stage of this disease. Advanced stage. At this stage, the infection will spread to deep layers of the stroma. Corneal ulcer in this case will be with a diameter more than 5 mm and can be central and paracentral. Surface of the ulcer has hoary infiltration. Necrotic tissue over the ulcer can be observed, as well as a more compact infiltration in the peripheral area. The ditch-shaped melting can be also a case in the marginal zone, as well as corneal ring infiltration, which can be complete, incomplete, and double concentric. I will continue with a few clinical samples. So here we can see a corneal stromal ulcer with a ditch-shaped melting centrally. Here we can see a moderate corneal ring infiltration, and in the first case with a diffuse stromal edema and overlying epithelium defect. On the second photo, we can see here a severe ring corneal infiltration without overlying epithelium defect. And on the third case, in the third case, we can see advanced stage with incomplete ring corneal infiltration and moderate stroma edema with hypopyon. So here we can see a corneal infiltration and severe stroma edema. Here, Acanthamoeba keratitis with a radial neuritis with a branching pattern, which can be seen as the nerves enter the cornea at the limbus. Late stage. This is a severe infection with a corneal ulcer which has a diameter more than 8 mm, can be also central and paracentral. There is a dense corneal stromal ring infiltration, obvious hypopyon, ditch-shaped melting in the marginal zone, which is deeper than in the previous stage. There can be a thinning and perforation of the cornea. Limbitis, scleritis, severe ophthalmodynia, orbital pain or severe headache with intraocular pressure, increased and secondary glaucoma. Here we can see a large and deep stromal ulcer with a dense ring infiltration and severe hypopyon, and the central area of the cornea is very thin. In this case, we can see a ring infiltration and limbitis with diffuse redness of the eye. In these two cases, we can see on the photo on the left, at late stage keratoscleritis with ditch-shaped melting in the corneal limbus, and the central corneal area is thinned with hypopyon. On the second photo, we can see a late stage of this disease with keratoscleritis with ditch-shaped melting involved in the corneal limbus and anterior scleritis. The possible complications of this disease are co-infection, anterior uveitis, secondary glaucoma, and anterior scleritis. And there is also can be a case of complicated cataract. Diagnosis. Clinical diagnosis is based on the risk factors. While we're collecting the anamnesis, it's important to pay attention where exactly the patient got the trauma. Then, of course, the progress of the disease, the information about the progression, and clinically we can also define based on the clinical symptoms which the patient might have. Those are, for example, ring infiltration, disc-shaped melting, crude salt-like granular infiltration, or radial neuritis, all those symptoms which I discussed already in a clinical presentation. Then the etiological diagnosis might be confirmed from corneal scraping, wet smear, staining, culture media, corneal biopsy, or confocal microscopy. The confocal microscopy samples are presented here, and those are characteristic Acanthamoeba cysts, which we can see here. Those are cysts with a diameter of around 15 micron, and both the wall of cyst and the contents inside the cyst show high reflective image. Differential diagnosis. So let's compare Acanthamoeba keratitis with viral keratitis. So risk factors. So in case of Acanthamoeba keratitis, there is always a trauma or history of contact lens wear, which is in viral keratitis, it's a bit different. So it's mostly fever, fatigue, emotional stress, or decreased immunity. Corneal signs, in the first case, it's pseudodendrites, no swollen epithelial borders, which are in case of viral keratitis. There is a typical dendritic ulcer, geographic ulcer, or marginal keratitis. And from a treatment response, in case of Acanthamoeba keratitis, we don't have any improvement from antiviral therapy, which is not the case in case of viral infection. The differentiation between Acanthamoeba and fungal keratitis. So risk factors are almost similar. From a medical history, in case of Acanthamoeba infection, epithelial punctate keratopathy is very characteristic. Then pseudodendrites, no purulent gray infiltration. There is a mild anterior chamber reaction at an early stage. And in case of a fungal infection, there is always, most of the time, a yellow-white purulate infiltration or ulcer, early anterior chamber reaction, and hypopion. From corneal signs, in the first case, there is a very rare satellite lesion might be observed, and in case of fungal infection, there is a typical ulcer with phythery margins and elevated edges and satellite lesions. It's a key characteristic point. And of course, lab analysis actually is very important in any of the infectious keratitis case. It's crucial. The differentiation between Acanthamoeba keratitis and bacterial keratitis, risk factors are almost the same. Medical history, in case of Acanthamoeba keratitis, the onset is a subacute or chronic. There is a slow progression, and there is non-purulent or gray infiltration. In case of the bacterial keratitis, there is always a rapid onset within 1 or 3 days, purulent infiltration, ulcer, early anterior chamber reaction with severe hypopion. From the corneal signs, in the first case, there might be a very rare satellite lesion observed, but in case of bacterial keratitis, there is no satellite lesion, purulent ulcer, and might be also necrotic tissue or discharge. And in terms of treatment response, in the first case, there is no improvement from antibiotics, and in the second case, there is a drastic improvement from antibiotics therapy. Medical therapy. Early recognition of Acanthamoeba keratitis has so far proven to be the strongest predictor of a good visual outcome. Most patients have very good visual outcomes with a standard regimen of 1 or 2 drug therapy. Let's continue with pharmacological treatment options. Anti-amoebic drugs. Those are aromatic diamidines, and those are one of 4 categories of anti-amoebic drugs used for treatment of Acanthamoeba keratitis, and here's the list presented of those drugs. The main function of them is that aromatic diamidines inhibit amoeba. Then there are also cationic biguanide disinfectants, chlorhexidine or polyhexamethylene biguanide, or biguanide, let's say like that. And also imidazoles like ketoconazole, fluconazole, miconazole, and clotrimazole. The main function of chlorhexidine is considered they considered as the most effective drugs for killing Acanthamoeba cysts, and this is a first choice of anti-Acanthamoeba drugs in clinical treatment, and it's very effective. And imidazoles eye drop, they may only be used in combination therapy with cationic biguanide disinfectants during the treatment of Acanthamoeba keratitis. Let's talk about effect of glucocorticoids. Glucocorticoids originally have no inhibition effect on amoeba pathogens. After treatment with amoeba-side drugs for 1 or 2 weeks, with improved condition of keratitis, moderate doses of glucocorticoids can effectively reduce the damage of the corneal tissue. The combination therapy using both amoeba-side drugs and glucocorticoids is safe for clinical practice, and topical corticosteroid drops should be avoided until the pathogens are not detected by repeated smear of the corneal scraping or by repeat corneal confocal microscopy examinations. Here we can see a sample of Acanthamoeba keratitis for 1 month, the infiltration corneal stroma without the corneal ulcer, and on the photo on the right we can see the progression after application of topical glucocorticoids for 9 days, and the corneal ulcer occurred. Therapeutic principles. What is important to know when we treat Acanthamoeba keratitis? In clinical practice, the therapeutic regimens should be selected according to different stages, early, advanced, and late stages, and the severity of the disease. The combined drug therapy is considered firstly. Generally, 2 or 3 types of antiamoebic drugs are selected for combined therapeutic regimen. The duration of drug therapy requires more than 6 months. Surgical management should be timely applied when drug therapy is failed. After surgery, anti-amoebic medicines are continued for at least 3 months. I will continue with the therapeutic regimens for patients at early stage. The therapy with topical anti-amoebic drug is the first choice generally. During the initial treatment, eye drops of anti-amoebic drugs should be applied hourly per day and night for at least 1-2 weeks. For patients with a corneal shallow stromal ulcer, the debridement of the corneal lesions can be carried out for 1 or 2 times in a week. According to the efficacy of treatment, eye drops are tapered gradually from once every 2 hours to 2 times per day. And during the therapy, topical anti-glaucoma drugs should be given in time if increased intraocular pressure is found. Treatment for patients at advanced and later stage. Besides the topical anti-amoebic drugs, oral terbinafine 250 mg per day or itraconazole 100 to 200 mg per day could be applied for 1 or 2 weeks. If the corneal ulcer is progressive or with obvious hypopyon in anterior chamber, surgical management should be needed as soon as possible. For patients at late stage, the corneal surgery has to be carried out immediately. After the surgery, eye drops of cyclosporin A 1% or tacrolimus 0.1% can be used with topical antiamoebic drug therapy for at least 3 months. Topical glucocorticoids should not be used in 1 month after surgery. Surgical therapy. Debridement and cautery of the corneal ulcer is the simplest surgical therapy you might apply. So here we can see the clinical sample of Acanthamoeba keratitis for 2 months. The corneal ulcer, ring infiltration, and hypopyon in anterior chamber were observed before the treatment, and here's the case after treatment with topical antiamoebic drugs, debridement and cautery, and the corneal ulcer was healed and hypopyon disappeared. Excision of necrotic tissues of the corneal lesions and amniotic membrane transplantation is another choice for surgical therapy. This is the corneal ulcer of a patient with Acanthamoeba keratitis for 1 month before the surgical treatment. And here we can see after the excision of the corneal lesion combined with fresh amniotic membrane transplantation. And this is the photo 1 month after the surgery. Most of the amniotic membrane was resolved and the ulcer was healed. And this is a half a year image after the surgery, and the corneal nebula was formed. And the corneal transplantation is the radical surgical therapy which you might apply as a surgical therapy for Acanthamoeba keratitis. Here's the cornea also of Acanthamoeba keratitis for 2 months, and this is the cornea after penetrated keratoplasty with clear graft cornea. This was everything about Acanthamoeba keratitis. Thank you for watching. Till the next video, stay positive, stay healthy. Bye.